Yeah, Dr. Shivyogi and Dr. Ravi Kulkarni will take it forward.
Okay.
I will be the backup man.
I'll just welcome and start.
Yeah. That's right. You will start.
You please welcome, sir, and I'll give a small introduction for this webinar.
Once they say yes, then I'll start. Welcome.
Yeah. We'll wait.
So you are live now. Sir, you are live. KP, sir, you are live. Yeah.
Yes.
You can start, sir.
Good evening, everybody. I'm very happy to welcome you all for the first webinar of KO Karnataka Ophthalmic Society this year, 2025-26. I'm very happy to welcome you all again. And firstly, I congratulate Dr. Shivyogi, our scientific committee chairman, and the whole team of scientific committee chairman for organizing this, and to the Microvision for helping us to conduct this. And I welcome Dr. Krishna Prasad and Dr. Ravi Kulkarni, who are part of moderation for this, along with Dr. Shivyogi. Welcome heartily the panelists of today, Dr. Deepti Joshi, Dr. Rupashri Matada, Dr. Pradeep Sagar, and Dr. Deepak Megur. I welcome all the participants of this webinar. We intend to conduct such webinars every month, the whole year, and I hope it will be more interactive and useful for all the practitioners, ophthalmic practitioners, as well as our members and students also. Thank you. Welcome again.
Thank you, sir. Thank you for those encouraging words. I'm happy to announce the first scientific committee webinar of KOS for this year on a very important topic that is all about high myopia. My sincere appreciation to all our expert panelists, which sir has already named, Dr. Deepti, Rupashri, Pradeep Sagar, Deepak Megur sir, and our excellent moderators, KP sir and Ravi Kulkarni. Give them a big hand because they are moderating this session. And I also thank all for contributing your knowledge towards strengthening scientific learning across our Karnataka state. I wish everyone a successful and meaningful academic session for this year. Thank you so much. Can we start?
Yeah, please.
So the first talk will be by Dr. Deepti Joshi, since it's a matter of high myopia that we are discussing. So it starts in children. Normally, the myopes, they become high myopes as they grow, and how to nip it in the bud. And we are looking at an epidemic of myopia in the near future, with so many children needing to wear glasses. So Dr. Deepti Joshi, she's a pediatric ophthalmologist and a strabismologist, MM Joshi Eye Institute, Hubli. So she has a vast experience in treating these myopes with different kinds of interventions apart from just glasses. So she's going to tell us how to nip it in the bud, how to actually curb this menace, and what we have it for the future. Over to you, Dr. Deepti.
Good evening, everyone. So at the outset, I would like to thank Shivram sir, Krishna Prasad sir, Shivyogi sir, as well as Ravi sir for this wonderful opportunity. So my topic for today is nipping it in the bud, correct concepts of slowing myopia progression. So this is a very common slide whenever we put it up. Is my slide seen?
Yes, ma'am. Very clear.
1 minute. So this is a very common slide that is presented always, that 50% of the world population will be myopic by 2050. But then what's the problem? Basically, because as the myopia goes on increasing, there is a very high chances of maculopathy, retinal detachment, cataract, or the glaucoma. And if you can see here, more then a -6 to -8 diopter myopia, the maculopathy becomes 40 times, retinal detachment becomes nearly 25 times of a normal child, and the cataract and glaucoma is maybe about doubles. So if you go -8 beyond, maybe maculopathy becomes more than double, like 126 times higher chances of maculopathy. So it's basically to prevent these complications which are associated with myopia that we have to halt the myopia progression. So the modern arsenal, which comprises of lifestyle modification, pharmacologic interventions, and the optical interventions, are the major steps through which we can stop myopia progression. So the most common and the most widely used myopia intervention is the pharmacological intervention, of which the low dose atropine has taken up the first step in the controlling myopia progression. So the low dose, basically we mean 0.01% and 0.05% of late, which has been introduced. So most common belief of the ophthalmologist is it basically reduces our accommodation effect, because that's what people think atropine acts as. But then no, atropine basically acts on the posterior segment of the eye, the sclera, retina, and the choroid. So overall, it reduces the axial length progression by acting on retinal receptors, the muscarinic receptors, scleral fibroblast, and the choroidal thickness. So it increases choroidal thickness, decreases axial length progression, and it remodels our eye with respect to the sclera. So the most important point whenever we have to start low dose atropine is we need to identify the progressors. So what do we mean by progressors? Whenever there is a change in a spherical equivalent of 0.5 diopter in a child, or there is an increase in the axial length of 0.2 millimeter per year. These are the children who are called as progressors. So an axial length documentation becomes mandatory in most of the children before you start the myopia, the atropine. So the moment you do this, we start a low dose atropine, that is 0.01% atropine. We check refraction once in every 6 months. So if the refraction is stable, then we continue this for a period of up till 2 years or 15 years, whichever comes later, not earlier. But if the child is progressing despite being on atropine, then you can do two things. Either you shift the 0.01% atropine, which we were using all these while, once in the night, make it twice a day, once in the morning, once in the night, or you can increase the strength 0.05% atropine once in the night, or you can add some other things like maybe optical, the contact lens, the orthokeratology maneuver we add along with it. So if the atropine is working fine in the child and the progression has been halted, stopping is something similar to your prednisolone. So you have to taper it. You can't stop it absurdly. It causes a rebound increase in myopia. So the tapering, there is no set rules till now available for tapering, but what I follow is I make it alternate day for 3 months, and then after 3 months you assess the child. If you feel your myopia progression has stopped, you can further taper it to maybe twice a week, then once a week, and then stop it off. But then at 3 months after making it alternate day, you see that the myopia is still progressing. In that situation, you bring it back to normal once a day dosage, continue atropine again for the next 2 years minimum. So now there was a AIOS focus group meeting, which I was a part of it, where they were reframing the rules of low dose atropine for the sake of children who are progressing. There were some changes which were brought. The age group was made 5 and above, safety age group. 3 to 5 is a question mark age, but you can still start it if you can document axial length progression, which becomes comparatively tough in that age group. Less than 2 years, why we don't start? Basically because if you start atropine and you hinder axial length prolongation, you can basically interfere with the emmetropization. Special scenarios which were strictly no previously now is being ticked yes to start atropine, like in children who have underwent cataract surgeries and are progressing into myopia, pseudophakic myopias. Those are the situation you can start atropine. Pathological high myopias of more than -6 previously was said as no, but now more than -6 and pathological myopias are also included for low dose atropine. ROP induced myopia can also be tried. You can say the parents that we have to start and we need to observe, but the chances that the low dose atropine works in such scenario may be comparatively less because the mechanism of myopia itself is different over here. Then there is a new set of children who are known as pre-myopes, that is who are less hypermetropic for age as compared to for that corresponding age, maybe a hypermetrope of plus 0.75 to a myope of minus 0.5. If these children have high risk, like for example parents are high myopes, or these children are more into digital activities, less time spent, less outdoors time spent, so these high risk children of a pre-myope can be prophylactically started on low dose atropine to prevent myopia progression. So these were some new things which were brought about in that study. So now if I have to summarize the low dose atropine, please start only in progressors. I have seen so many children, the moment they are diagnosed as myopia, atropine is being started. What happens? Once you start atropine in a child, minimum of 2 to 3 years you cannot stop. And if you stop in between, a child, we don't know whether the child was really a progressor or a non-progressor. If he stops, he will definitely become a progressor. So we are making a child progressor by starting myopia in a non-documented progressor child. So please don't start in the first sitting of diagnosed myopia. The chances of rebound myopia is very high if you stop absurdly. So please tell the parents, don't stop it. Counseling is mandatory. This is a long treatment. You have to use it daily once in the night. Even if it's over, get it from the medical shop and continue it, but don't stop it. This becomes a mandatory message which has to be put to them. The lowest concentration has to be started first, despite the higher concentrations available nowadays. The next most important point, most of the progressive myopias, even if they are -2, -3, because of that rapid progression, we are noticing lattices in them. So if you notice a progressive myopia, retina evaluation becomes mandatory, even if the child is maybe less than 6 years to 7 years, and even if the child is in low myopic state. So make sure of all these things. Now we spoke about few children in whom the atropine was not working. So that is where the optical method comes into role. So this is based on the principle that if you give a simple concave lens to treat myopia, there is a set of rays in the periphery which do not focus on the retina and results in hyperopic defocus. Because of this, the eye thinks, array, the rays are going beyond my eye. Let me just elongate myself to bring the rays on the retina, and this is what is happening and the myopia is progressing. So we have to tackle this hyperopic defocus, whatever may be the optical method that I would be describing. The most common one is the defocus incorporated multiple segment or the DIMS lens. So what basically is the DIMS lens is, there is a central zone of 9 millimeter which is meant for distant vision. Surrounding it, there are small lensets which are available, and these lensets are of about 1 millimeter diameter. Nearly 400 lensets are there, and each of them have a plus 3.5 myopic defocus. So this in turn results in a myopic defocus rather than a hyperopic defocus. Similar way, the next lenses which were introduced in the market were the HALT lens, that is highly aspheric lensset targets. Here, instead of this plus 3.5 spherical lensset, we are putting aspheric lensset along that center 9 millimeter, and that in turn causes a volume of myopic defocus. So not a hyperopic, rather a myopic defocus. Instead of this aspheric or spherical lensset, if you put some diffusers around the central 9 millimeter, that results in dot lens. So basically what these diffusers do is, it actually takes care of your contrast sensitivity. There is a thought process that most of the myopes basically have some cones which are less working, and the surrounding cones of those less working cones are overworking to compensate. So this abnormal contrast sensitivity may be responsible for the axial length prolongation, and to take care of this abnormal contrast sensitivity, that is the higher contrast sensitivity of the surrounding cones, are reduced by these diffusers which are surrounding the 9 millimeter. Now instead of this diffusers, if you put some cylindrical lensets, that is when becomes the CARE lens, that is cylindrical annular refractive element lens. So basically what are the glasses doing? Central 9 millimeter zone has the distance correction. Surrounding it, you can have spherical of plus 3.75 lens sets, aspherical small lens sets, or some small diffusers or some cylindrical parts. So these things are basically taking care that the axial length prolongation is not happening either by changing contrast sensitivity or by changing your hyperopic defocus. Similar things are now available even. So these all lenses are now studied together. If you compare, they have reached a conclusion that DIMS halt dot works wonderfully to control myopia progression. But there is the case study is still maybe a bit in the dicey situation, but these three have given a real good evidence-based progression control of myopia over a period of 1 year. So all these similar principles are now available in contact lenses also for those children who don't want to wear the glasses. So that is your multifocal contact lenses, dual focal contact lenses, extended depth of focus contact lenses. So all of these types of soft contact lenses are available. In case this is not but the point to be noted is these are not mostly FDA approved in places like America and Dubai, and these are the children mostly using the orthokeratologies. So in India, orthokeratology slightly lags behind in our Karnataka state, basically because it's a bit expensive and the affordability plays a very important role. So in case of orthokeratology, you're basically placing a cornea, the contact lenses over the cornea overnight, and you're reshaping the contact lens. So basically because of which you're causing a mid-peripheral myopic defocus, and that in turn is halting myopia progression. So now if I have to summarize the optical intervention, whom do we start? Those children in whom the low dose atropine is not working, or in those children in whom the children is progressing despite low dose atropine, children who are not compliant with low dose atropine, or you document a peripheral hyperopic defocus by doing a peripheral refraction in the first sitting. In those situations, we can start off the optical intervention. Again, same thing. Please start it in progressors only. They don't start it in case of the primarily documented myopes. Many optical shops are giving all these lenses even for astigmatic children, doesn't work at all. So please do inform your parents that these things are easily marketed by many optical shops even to non-myopes. So parents have to be very careful when they are selecting the spectacles and not fall into the prey of the optical marketing strategies. And the previous thought process that if you undercorrect a child with myopia, let the child get adjusted, sanda number in the shuru madana, then we will give all this will increase the progression. So there is no role of undercorrection in case of myopias. But despite whenever I start any maneuver, if it doesn't work, parents come and tell me, "Endri madam, ishtella madidvi, adru increase ಆಗ್ತಾನೆ ಇದೆ number." We have to remember that it is a combined effect. Parents have to put effort with us. The lifestyle modification still carries the highest point in myopia progression halting. Child has to spend nearly 2 hours per day outside the home. Lighting has to be taken care of. A very good lighting when the child is studying. Avoid LED bulbs. Mobile distance, larger screens, 20-20-20 rule has to be taken care of, and a good and healthy lifestyle of adequate sleep and a very good diet plays a real important role with respect to the progression of myopia. So with this, I would like to conclude that myopia progression halting is basically a platter of dishes buffet spread out in front of us. So it is with respect to us, you need to assess the parents' affordability, the parents' compliance, the child's requirements, and the various clinical tests results which come out in the OPD. So put all of these together and select the best one, which is the best for the child, the family, and as a whole when you are managing a child with myopia. So with this, I would like to conclude my talk. Thank you once again.
Thank you, Dr.
Yeah,
Deepthi. I think
yeah. Thank
it's
you. Thank you. Yeah.
it's
Thank
a
you. It
dinner
was a
time. Your last slide was very distracting, actually. It's dinner time.
Thank you,
Okay.
sir.
So,
sir.
just
I
one
think we have to
question.
wait for another 1 hour for dinner.
Dr. Deepthi,
Yes, sir.
most people think that myopia progresses, okay, as a normal rule, just like the body grows, the eye grows, and myopic progress. Somebody, a child at 5 years with -1 would definitely end up with -2, -3, -4, whatever by 18, 20 years. Is this progression normal or any? Because most people wouldn't really bother unless it becomes really a high myope or something like that. Some amount of progression is inevitable despite whatever you do, or can you really halt a myopia at whatever stage you diagnose with?
So basically, now it's changed as we are not halting myopia progression, we are just slowing myopia progression. We cannot completely stop the myopia progression because emmetropization is a part of the life. When the child grows, there is some amount of growth which is happening in the child's eye also. That's why we don't call, maybe the progression itself is said that 0.5 per year is considered. More than that is considered as progression. So be less up to 0.5, we are thinking still that a 0.25 is still an acceptable change because some amount of growth is happening, and in fact it should happen. That's why I said we are not starting low dose atropine in children less than 2 years, because we will in fact affect the emmetropization process. We will in fact affect the normal growth process of the eyes also. So it can never be a complete halting of the progression. We are just taking care, maybe we are slowing the progression of the myopia. So everything cannot be stopped. Maybe it's like not letting the child grow in the height at all and telling him stop at this point. That's not possible, maybe.
Thank you.
Thank you, sir.
Thank you, Dr. Deepthi. You have really enlightened all of us about current concepts of slowing myopia progression. That was a
Thank you, sir.
wonderful talk.
Deepthi, last one,
Now
small
it's
doubt
time
from
yeah.
my side.
Yes, sir.
How
Yeah,
to
Ravi,
do
go ahead.
peripheral refraction?
Sir, peripheral refraction is available already as a peripheral refractometers. It is available as a machine. But for people who cannot really afford a peripheral refractometers, even a simple retinoscopy, dilate the child very well and ask him to look at a far point beyond you in extreme right and left gaze. You can still do a peripheral refraction even if you have just a retinoscope in your OPD. And now that retinoscope holder attachments are coming for at a very less cost in many many places. So you can just attach the retinoscope head to a holder and ask the child to look at an extreme far point on the extreme right gaze, extreme left gaze, and do off the refraction. So you are doing the refraction in extreme peripheral gazes, sir.
Okay.
But a perfect dilatation is mandatory for that.
Okay. Thank you.
Thank you, sir.
Thank you. Now I call upon Dr. Rupashri Matada to speak on her topic, that is refractive solutions for high myopia, birthright or luxury. Dr. Rupashri is a wonderful phaco-refractive surgery at Prabha Eye Clinic. She did her DOMS in JJ Medical College, Davangere. I was her junior. You can take over the mic, Dr. Rupashri.
Thank you, Shivyogi, for that kind introduction. Are my slides visible?
Yeah.
Let's go ahead.
Exactly. Very nice.
Okay. So at the outset, I would like to thank Dr. Shivyogi and the whole COSCON KOS group for inviting me for this talk. I'll be speaking on refractive solutions for high myopia. So is it a birthright or luxury is the question. By the end of this talk, we'll be able to answer that as well. I have no financial interest in many of the things we'll be using here. As Dr. Deepthi rightly mentioned, that myopia is a huge epidemic. And here I will be discussing mostly about more than -6 diopters of myopia, when to consider surgery, adults with stable refraction, and essentially normal or within normal assessments of the cornea biometry and anterior chamber, these patients will be considered for surgery. These are the FDA approved parameters for all the cornea-based and lens-based surgeries. So basically in cornea-based surgeries, we will take up photorefractive keratectomy, LASIK, which could be microkeratome assisted or femtosecond laser assisted, and lenticule extraction. So I'll be presenting a few cases. My first case is that of a 33-year-old female who had, this was her refraction, -6 with -1. You can see essentially the pentacam is mostly normal. with a good regular astigmatism, and she has a good thickness of 573 microns. The other eye is also similar. So pre-operatively, we do certain measurements in all cases of laser vision correction on the cornea. So why do we measure the axial length? Because some patients post-surgery 3 to 5 years later may come back with certain amount of myopia, and it enables us to compare this with the basal or the baseline values of axial length and to see if they're having axial myopia. The next one is the score which comes on the anterion, which is the screening corneal objective risk of ectasia. If this is negative, it is good. If it is positive, there is a risk of ectasia. White to white, it is important for all cases of femtosecond laser LASIK because we can adjust the flap diameter. And specular should be done in all cases. In some cases, we could be getting a pseudo thick cornea. Like in Fuchs, we could be missing some early cases of Fuchs on slit lamp examination. So it's always a good idea to keep a specular microscopy ready before you do the surgery. And of course, we all know that laser vision corrections are associated with dry eyes. So a mandatory Schirmer and probably a lipid layer thickness would also help in dry eye evaluation. Once we have all this in hand, we have to have some calculations like the flap thickness. The flap thickness in femtosecond laser assisted LASIK will be like 110 microns with the LensX machine. That is the least we could go. And ablation depth by Munnerlin's formula for every diopter of correction, 14 microns of cornea is thinned. So you multiply that with the whole of the correction, like here 7 diopters, and you get a value. That is your ablation depth. And the residual stromal bed, when you subtract the sum of flap thickness and ablation depth from the central corneal thickness, you get a residual stromal bed. So different institutes have different cutoffs. So here at Prabha, we follow something between 330 to 350 is our cutoff. Less than that, we don't go for LASIK. Percentage tissue altered. Percentage tissue altered when we divide the sum of flap thickness and ablation depth by central corneal thickness, we get the amount of tissue we have altered by the laser. So that should not be more than 38 to 40%. The flat K. Why the flat K is important? Because in laser vision correction, we are flattening the cornea. And when we flatten the cornea, it should not go beyond 35 diopters. If it goes, it will lead to a lot of aberrations and a lot of night vision issues. So how do we get the flat K? So you multiply the refractive error by 0.75 and subtract it from the preoperative flat K. So that will be your postoperative flat K. So once we do the docking, this case was taken up for femtosecond laser. You adjust the flap to the center of the pupil, and now the bed cut starts. Once the bed cut is done, the side cut is done. The beauty of femtosecond laser is you can change the flap diameter. You can change the hinge. Wherever you want, you can place the hinge. Because the cylindrical power here was at 180, was in the horizontal axis. We don't want the ablation to happen on the hinge. So we have kept the hinge superior. So then you have to slowly separate the tissue bridges, dry the bed, and then do a femtosecond, excimer laser. Post the excimer laser, you have to reposit the flap. And while repositing the flap, the interface has to be washed well. And you can see that the femtosecond flap, unlike the microkeratome flap, sits very well in a, the side cut is very perpendicular. So it sits very well. You can see that nice groove on the sides, which is well approximated. And you can use a slit lamp to see the interface. So post-operatively, you can do an anterion and to see how nicely the flap is opposed to the bed. The second case is that of a 24-year-old female who had, this was her refractive error. So you can see again on the same parameters, the pentacam looks quite normal. The K1, K2, Kmax and the corneal thickness is quite good. 540 is a good thickness. So here we plan to do a epilastic or PRK. The flap thickness will be 50 microns, and the ablation depth RSB and PT are well within normal limits. So this was one extra epithelial thickness map should also be done in cases of PRK to see if the epithelium is regular. So once we use alcohol assisted epithelial removal, 20% alcohol is used to loosen the epithelium, and used for around 30 to 40 seconds, and nicely the epithelium comes off like a flap, and then we dry the bed and again go ahead with excimer laser. Here in cases of PRK, it is important that post laser we use mitomycin C to reduce the effects of scarring. When we do higher powers, there is a risk of scarring in these corneas. So we use mitomycin C around 30 seconds for up till 3 diopters. After that, for every diopter, we increase it by 10 seconds. So in this case, for 6 diopters, we used almost a minute of mitomycin C. So in spite of all these precautions, you see that when we do higher dioptric powers, we can end up with some cases with post PRK haze. So intra-op MMC definitely has a role, and these patients should be kept on long-term steroids like fluoromethalone for 2 to 3 months. Myopes, you have to know that are mostly steroid responders, so you have to keep a very close watch on the IOP. UV protection glasses post-operatively for around 3 months is mandatory, and cyclosporin also can be given in the usual BD dosage for a duration of 3 to 6 months to prevent scarring when we do higher powers. Post-PRK haze risk factors are mostly in cases where we do for high myopes and for PRK enhancement, and most of the corneal problems are also secondary risk factors. So early onset haze can be treated with steroids, but late onset haze, which happens after 6 months, should be or might have to be treated with surgical intervention like mechanical debridement or superficial PTK. SMILE is a less invasive procedure where the lenticle thickness limits extreme corrections, and it is FDA approved for the mentioned dioptric powers. So why cornea-based approaches struggle when it comes to high myopia is because tissue constraints. There is a limit to how much we can thin the cornea. And in the race to save tissue, we reduce the optical zone. And optical zone reduction itself has its own risks because you'll have a very small optical zone which will be very flat. And when the pupil dilates beyond the optical zone, patient will have lots of photic phenomenon. Biomechanical stability is also a concern because when we do for high myopes, we're always worried about post-LASIK ectasia. So if and when the following parameters are met, we go for a corneal based procedure. Otherwise, we go for lens-based procedures. So what are lens-based procedures? Like phakic IOLs and refractive lens exchange. So when we cannot get away with doing only these two, we go for bioptics, where most of the correction is done with either phakic IOL or refractive lens exchange, and the rest of the myopia is corrected with a laser-based correction on the cornea. So phakic IOLs have excellent safety profile and are highly predictable, and there is no cornea tissue removed. So this, I'll be presenting another case, which is of a 26-year-old female who was a high myope with -12 with 1.5. Her pentacam is essentially normal. And you can see that it is very important to note down the endo ACD, or in pentacam, as we say, AC depth internal. So many times we just get the antechamber depth. It is not enough to just know the antechamber depth because that might include from the epithelium. So it is measuring 500 microns of cornea too. So it is false. So you have to know that the endo ACD has to be more than 2.8 for a phakic IOL. Here there is a good endo ACD. And it is important to measure the white to white. The white to white can be measured in many ways. The IOL master gives a good white to white, but usually tends to overestimate the digital caliper white to white by around 0.5 millimeter. So here we go to the OT, make the patient lie down, and under the microscope, I take around 5 to 6 measurements and take an average of them with the digital calipers. So why is this candidate not a good candidate for laser correction? Is because our RSB, PTA, and flat K, everything is abnormal. We have to decide on going for a ICL in this case. So this is the other eye, similar parameters. So in ICL, we have to be very careful. We have to have a specular microscopy to see how the endothelial cell density is. We need to do a antersegment OCT or a UBM to see the configuration of the iris, if there are any irises, plateau iris, or any such abnormalities, or even if microspherophakia is there. Such kinds of things we can see on the antersegment OCT. Then a good biometry is always a good idea because we are taking the axial length in it. The antechamber depth is again reconfirmed, and also we have a value for their future in case there is a cataract in future. We also have a like a set value. Also, macular OCT and glaucoma OCT need to be taken because myopes can have primary open angle glaucoma in future, and they can blame it on the ICL. So we have to be sure that we have a baseline recording, and it is mandatory for them to come back and get their glaucoma and retina checked every year. So this is a case of ICL being loaded. So you have to see that the leading haptic will have a hole on the right side. You have to hold the ICL and not pull the ICL. In fact, you are retracting your cartridge so that the ICL moves forward. Loading, if the loading is done well, half the work is done in ICL. So after that, you make side ports and the main port, and you fill in the viscoelastic in strands. It should not be overfilled, otherwise the ICL will not open properly. It will be in a tight scroll. So when you are injecting, be very slow and gentle in injecting, and see that the hole, the leading haptic, the hole is on the right side, and then only inject the rest of the ICL. You can always retract the ICL if it is opening the other way around. So then you tuck the haptics with a Woolwich manipulator under the iris and make sure to remove the viscoelastic nicely through the centraflow hole. And that's the end of the surgery. So the vault measurement is very important. Vault is the distance between the posterior surface of the ICL and the anterior surface of the lens. This should be ideally between 250 to 750 microns. Or on the slit lamp, you can just evaluate like half corneal thickness to 1.5 corneal thickness. Here you can see it is vault is very good in both the eyes, right and left. It is around 500 microns, which is almost equal to the cornea. So take-home message in ICL procedures is it is a reversible procedure. Post-op yearly glaucoma and retina check is a must. No adjustments in biometry needed. Avoid eye rubbing because there are cases of rotation of toric ICL when patients rub their eyes, and at all costs you have to avoid trauma, because here we have seen horrible cases of trauma where the ICL has in one case just come out along with the lens, and in another case where through the zonular area it has gone into the vitreous. If there is increase in myopia seen post ICL, keep in mind axial myopia or nuclear sclerosis. So I come to the fourth case, which is of a 39-year-old female who had undergone barrage laser and scleral buckle in the right eye. She was status post ICL 16 years ago for very high myopia. Her vision was less in the right eye because of macular degeneration. So essentially her left eye was a good eye, and myopia was progressing secondary to nuclear sclerosis. When we did her biometry, it was around axial length is 33 and her IOL power was coming to -4. So this is a case of ICL explantation followed by cataract surgery. So ICL explantation is, it comes out very nicely through a 2.8 millimeter incision. So basically you exteriorize the haptics, then hold on to one part of the ICL and use a hand over hand technique and pull it out. The rest of the cataract surgery is like any other phacoemulsification. So the expand series or the three-piece lenses are available from -5 to +5. This was a -4. It is very important that we reiterate to the person who is ordering that it is -4 and not +4, because when they order lenses, they usually are not used to minus numbers. And three-piece lenses implanted in this case. So coming to refractive lens exchange, it is best for older adults. And we have to always know that refractive lens exchange carries a 1% chance of retinal detachment in these eyes. And this is another case where a 21-year-old male who had unilateral high myopia. You can see that the right eye had only -1 cylinder, whereas the left eye had a huge sphere with a -4 diopter cylinder. He was not eligible for ICL because his AC depth was 2.6. So his you can see that he has steep corneas on his pentacam. And this is his anterior showing 21 millimeters of axial length in the right and 27 in the left. And on biometry, you see that the left eye IOL power is coming around 6. So this was we did a clear lens extraction with +6 diopter sphere and cylinder of 0.5. We used an IQ T7 lens. So the myopes, you have to keep your bottle height low, and clear lens extractions are like it's mostly aspiration and then irrigation and aspiration and putting the IOL. I'll just run this through. So LIDRS is also a commonly seen phenomena in myopes. So the last case, this is of a 48-year-old female who came with very high myopia. She was a contact lens user and had severe vascularization, and she had also had one episode of healed contact lens induced keratitis in right eye. If you can see her pentacams and a slit lamp photograph, there are inferiorly large cones with Kmax of 70 diopters and a corneal thickness of 350 and 360. So we planned to do a DALK because she had severe keratoconus. We did a DALK and post-DALK. This was her refraction from -24. It reduced to -12. And this is very interesting slide where you can see that once the DALK was done, the K readings reduced from 53 to 42 and 55 to 47. And the IOL power, which was -16, which is very difficult to get, it dropped down to -1. So at this stage, we went ahead and did a cataract surgery in her post-DALK. And I'll just run through this video. So we did -1 diopter sphere IOL was implanted. And uncorrected visual acuity, she improved to 6/9 parts. So these patients who have very high myopia, we have to see that their cornea is, you have to see their pentacams and see whether their cornea, we can regularize the surface and then go ahead and do something for them for vision. So basically, I'll be just going through some studies. So comparing LASIK and PRK, there are equal number of disadvantages of both when we do in high myopes. So PRK, there is the risk of haze, and LASIK, there is the risk of ectasia. And phakic IOL is any day safer when we are doing for very high myopes. And high levels of functional improvement and satisfaction is seen in myopes when we do these refractive surgeries. Though a small percentage of patients complain of nighttime driving. So when coming to a decision algorithm to conclude, less than 40 years, ICL is preferred. 40 to 55 ICL versus refractive lens exchange. More than 55 years, better to go for cataract surgery or refractive lens exchange. And laser vision correction only if the cornea is ideal. So to answer the question whether it is a birthright or a luxury, I would say it is a birthright, because just imagine standing at a signal, not being able to see what is passing if you have lost your glasses or something like that. So I think it, as ophthalmologists, it is our prime duty to help these high myopes see better. Thank you.
Thanks a lot, Rupashri. That was a wonderful presentation. In fact, I took a screenshot of last slide. I have one question, Rupashri.
Yeah.
There is something called effective lens position, or called as ELP in myopic cataract surgeries. Okay.
Mhm.
So in those cases, would you like to use CTR in all cases, or how you assess those cases?
So it is difficult to assess who will need CTR to improve the effective lens position. But in toric IOL, when there is high powers like in pellucids or keratoconus, it is better to use CTR to enable the toric IOL to sit properly. Otherwise, there are cases which have rotated because the bag size is also big. And the lenses, what are manufactured, usually don't occupy such a huge space. So in torics, it is a good idea to use CTRs, but in regular myopes, we usually don't use CTR unless absolutely required.
Dr. Rupashri,
Yes, sir.
excellent compilation. One very important question: why even though India has so much of myopic population, why our refractive surgery statistics are so low? What do you think is holding the youngsters to seek refractive solutions in our clinics?
Cost.
Because of the expense involved, sir. It is quite an expensive surgery.
But they have money for everything else.
Yeah.
The same family goes for a Europe trip next month. Okay, they will probably have given a charity of 10 lakhs to a temple. So it's a lifetime thing. In fact, they will spend 3 times the money for spectacles in next 50 years, no?
It is a mind
Cumulative.
block in their this thing, I think.
Shall I answer,
Nobody
sir?
wants to spend
See,
money on healthcare.
No. This is not covered under scheme. Somebody does some politics and introduces in all CGHS, Yashaswini, probably patient might come in queue.
No, this is not a segment which is going to, which will need help from Yashaswini. This is even the matter of in middle class or high upper classes, which we see that they don't come for follow-ups after ICL and or any other surgery. They think it's once it is done, it is done. And every time when they come, if we ask for some scans, they are very skeptical about it. We have to explain ourselves that why we are getting a scan done. So that is a very sad part, I feel.
No, my question is like these IOL manufacturing and ICL manufacturing, is there a huge cost incurred, difference in between these two? If that is not the case, if there is not much difference, then these ICLs can be manufactured with a lower rates by Indian company, something like that. That may be an answer for some of the patients. Cost is definitely a hindrance. Many patients deny because of the cost.
Ravi, there are already ICLs, no? Indian ICLs in the market, which are quite cheaper when compared to the Star ICL.
Yes.
So still they are costly. Still they are little costly. They should come to the price of a hydrophilic Indian IOLs. Then everybody will start putting.
See, it is all the mindset of the doctor, I think. Let's discuss it
Maybe
later.
sir, you wanted to tell something?
Yeah, actually, see, if there are more patients coming, the cost will come down. That is the paradox. Always, when there is less number of people seeking it, the costs always are exorbitant. Like it's a demand supply thing. So I think, to answer my own question, I think it is all the problem is with the ophthalmologists. See, we are divided over the refractive surgery. People who do not have access to refractive surgery normally are not very encouraging to the patient to seek. And we don't sow the seeds of this counseling right in the beginning. When we see a myopic child, from that time, if the parents and even the child itself is told that there is a solution at 18 or 20 years, we can't suddenly say. And the same thing, the whole society is against a refractive solution. They have confusion about so many. And if you see YouTube, you will find so many shortcuts and Ayurvedic treatments and eye exercises for getting rid of glasses. So basically, as a community, we are not working towards it. If everybody speaks the same language, if you are able to convince a child wearing a myopic spectacle that there is a solution ahead, and if you can understand the commerce of it, as I told you, the amount of money spent by spectacle wearer is huge compared to the amount of one-time investment. That is very important. And apart from all the problems of wearing a concave lens, the shortening of the visual fields, the minification factor, the aesthetic factor, the, the dependence on glasses, the quality of life, I think these are the things. And I never take the answer as cost. It is never the commerce. They can always, they have a 5G network, they have the iPhone, latest iPhones, and only thing is when it comes to an ophthalmic surgery, they say there's no money. And it's a one-time investment. It is for a child. When an 80-year-old man is opting for a trifocal lens, who is probably going to live for 10, 15 years, a boy or a girl at 20 years, it's a lifetime investment, no money, and that too, it is for both eyes. Sometimes most of the LASIK is done for both eyes.
Yeah.
Actually, that they don't consider. It is for both eyes, we say whatever the amount. It is not for one eye. Where cataract, it is only one eye, we say. So I think all these, the commerce of refractive surgery itself needs another webinar by itself. I think well done, Dr. Rupashri. I think we can go ahead with the next talk.
Sir, can I put in one word?
Yeah.
One of my patient who now became 18 years, the problem is most of our patients, they don't approach ophthalmologists for spectacles. They are still going to spectacle shops or optometrist for the specs because they think things happen very easily and beside their house they are getting specs. And many a times the spectacle shop people are still propagating specs, glasses as or contact lenses as compared to refractive surgery. So it's only 20 to 30% of the people who approach an ophthalmologist for glasses. It is still they get redness or surgery or squint. They don't approach us much for glasses patient, even for a pediatric age. I think our marketing strategy, our information strategy should change with respect to this part.
Yeah. And the spectacle and a optical shop will never probably spoil his own practice by suggesting a refractive surgery.
He
That
has
will
in
be.
fact told that child side effects ಭಾಳ ಇರುತ್ತೆ ಇದು ಭಾಳ ಇದ್ರದ್ದೇನು
Correct.
side
You're right.
effect ಇಲ್ಲ ಸೊ
Yes.
ಹೊರಗಡೆ ಹಾಕೊಳ್ಳೋ ಚಶ್ಮಾ ಇದು ಹಾಕೊಂಬಿಡಿ so the parents really had a tough time agreeing to our refractive surgery which because 18 years they were told by the optometrist that specs is the safest aspect.
Definitely there's a side effect for his business. That's what he's telling. He's telling the truth.
Correct.
Yeah. Thank you, Dr. Rupashri.
Dr. Pradeep is here, sir. You only introduce Pradeep.
I think Dr. Pradeep Sagar is one of the a very prolific vitreoretinal surgeon, extremely good academician, and a very good teacher. He works at Shankara Eye Hospital, Shumaga, and he has been one of the most well-trained VR surgeon. And he's going to speak on a very important topic. We all talk about high myopia and its problems to maintain good vision till the end of their lifetime. And the retinologist has a greater role to play. We have so many patients losing vision because of a retinal detachment, myopic maculopathy, and so many other problems associated with high myopia. So it becomes a burden, rather a responsibility for an ophthalmologist to seek the help of a retinologist in salvaging the vision for an entire lifetime. I think we have no better person than Dr. Pradeep Sagar to cover this very arduous task and a very important task. Over to you, Dr. Pradeep Sagar, for salvaging the vision in a high myopia.
Are my slides visible?
Yeah, you can go ahead, sir.
Good evening, everyone. At the outset, I would like to thank KP sir and Dr. Ravi Kulkarni sir for giving me this opportunity. I will be discussing about salvaging vision in high myopia for a lifetime. So all of us are aware that other than the other conditions which can result in vision loss in a patient, high myopics are prone to a certain other conditions which can result in further vision loss. So I will be discussing this presentation in these three headings. What are the threats to vision in high myopia? how to screen or detect these threats early, and how a prompt and regular treatment helps in preventing the vision loss. So the first threat I will be discussing would be choroidal neovascularization. So I will be discussing my first case. A 25-year-old male presented with metamorphopsia since 1 week. His best corrected visual acuity was 6/12. On fundus examination, we can see that there were 2 separate patches of subretinal hemorrhage. On OCT, we can see that there is subretinal hyperreflective material corresponding to this hemorrhage, but it does not confirm the presence of a choroidal neovascularization. So we did a fluorescence angiography. In this, we can see that within that rectangle, there is a block fluorescence, there is no leak. So it indicates that it's a subretinal hemorrhage due to lacquer crack, which can be just observed. Whereas here we can see that there is a hyperfluorescence, which is increasing in intensity and size, suggestive of leak, which indicates that it's a choroidal neovascularization and requires anti-VEGF therapy. So he was treated with ranibizumab, and we can see that there is a regression of neovascularization and subretinal hyperreflective material. So another case, a 48-year-old lady presented with metamorphopsia since 1 week. Her best corrected visual acuity was still 6/9. The fundus examination would show that there is a focal chorioretinal atrophy, but a careful examination would show that there is a tiny hemorrhage. So if we do an OCT through that area, we can see that there is a subretinal hyperreflective material, which indicates that there is definitely a hemorrhage and probably there may be a CNV. In this case, we did an OCTA. We could see that the flow signals within the subretinal hyperreflective material and a vascular network in the outer retinal slab, which confirms the diagnosis of choroidal neovascularization. So we need to understand that CNV close to fovea in a myopic usually present with sudden onset symptoms, particularly metamorphopsia, and they are rarely asymptomatic. The clinical examination findings can be very subtle, and we should never ignore patients' complaint in terms of, particularly if it is metamorphopsia. So OCT is a good tool for identifying these cases in suspected scenario. FFA and OCTA helps in confirmation of the diagnosis. So this is the second patient that I discussed. She was treated over 4 years for multiple recurrences with 15 anti-VEGF injection, and we can see that the visual acuity is still maintained, though there is an increase in the atrophic maculopathy component, but still the foveal ellipsoid zone is intact. Whereas if we just go back to the right eye of the same patient, which was a neglected case from her end, and we can see that the visual acuity was 3/60 when she presented with the symptoms in the left eye. We can see that there was an active neovascularization, but it was already chronic. We gave an option of anti-VEGF therapy, but discontinued treatment due to no improvement in vision. We can see that the lesion is inactive, but there is a foveal atrophy and there is a subretinal hyperreflective material, which resulted in a poor outcome in this patient. So the CNV in myopia generally responds very well to anti-VEGF therapy, and some cases do recur frequently and may need a long-term therapy. But in cases with late presentation and inadequate treatment, the prognosis will be poor. So an early identification and prompt treatment is very much essential. So moving on to the second threat, the myopic traction maculopathy. So in this case, we can see that it's a 45-year-old lady, not sure of the onset of vision loss, and the visual acuity was 1/60. If we see the fundus, we can see that there's a localized detachment and it looks like there is a lamellar hole. But when we did an OCT, we can see that there is a neurosensory detachment, a thin fovea, an inner schisis, and an outer schisis. So this is a typical case of myopic traction maculopathy, but presented pretty late, as we can see that the fovea is pretty much thinned out. So in these cases, we usually consider a pars plana vitrectomy with or without a foveal sparing internal limiting membrane peel. In this case, post PPV, we could see that there was a resolution of NSD and schisis. The foveal contour did come back to normal, but the EZ was significantly lost and the vision did not improve much. This is mainly because of the longer duration of the disease. Whereas in this patient, if we see that there is a right eye which appears like an atrophic maculopathy, but the patient was absolutely asymptomatic and the patient had come for his symptoms in the left eye, which had a retinal detachment. The best corrected visual acuity was 6/9. But if we do an OCT, we can see that there is an inner and outer schisis. There is no NSD at present. In this scenario, we need to understand that MTM is mostly asymptomatic and it usually presents with a gradual progressive vision loss, and OCT is a very good tool to detect early stages of MTM. Clinically, there may be a subtle sign such as an elevation of the blood vessel, but we may miss them in a good number of cases. So in this patient, since the vision was good and this was the first time we were seeing the patient, we decided to observe, and we would definitely consider a surgery if there is any worsening of visual acuity or the OCT shows any worsening of schisis. If we operate in a slightly earlier stage, we will be able to maintain a good vision. So the third threat is the one which is most dreaded, and which is retinal detachment. When it comes to retinal detachment in myopia, we encounter three scenarios. One is RD due to an atrophic hole. In these cases, the patients are generally young, the vitreous is still formed, and what happens is there would be a minimal vitreous liquefaction, and this liquefied vitreous would migrate through the hole into the subretinal space and would result in a detachment. And the detachment in these cases would be usually shallow, and the significant amount of vitreous is still formed. So these are ideal cases for scleral buckling, and they progress very slowly. And if they are detected very early, we can even consider a laser barrage if it is only in the periphery. So we need to understand that the lattices and atrophic holes are actually quite common in myopia compared to emmetrope. But in myopes, the moderate myopics tend to have these more than pathological myopia, which is something which is we need to be aware of. We can't say that it's a moderate myopia, so we need not worry. It's actually lattices and holes are more common in them than eyes with pathological myopia. And this has been documented in multiple studies. So in these cases, we need to regularly examine these patients and identify the holes and lattices. And we should consider a laser barrage in cases of neurosensory detachment around the hole, though it is a bit controversial and largely depends on individual physicians' decision and priorities. So usually, as I mentioned, scleral buckling would be the first choice of surgery in these cases. So the other scenario would be RD due to a retinal tear. This is usually PVD induced. In these cases, there is a significant vitreous liquefaction, and this liquefied vitreous will migrate through the breaks in the posterior cortical vitreous. So once they migrate through the breaks in the posterior cortical vitreous, they eventually result in development of PVD and results in retinal tear. I think there is some issue with the video as such. These detachments usually tend to be bullous, and they usually present with acute symptoms. So we need to understand that PVD occurs at a very younger age in pathological myopia due to early liquefaction. And we need to understand that the higher risk of break is mainly due to the strong vitreoretinal attachment in younger age group. So the PVD-induced retinal traction would result in flashes, and the retinal tear and bleed would result in multiple floaters. So if a patient presents with these symptoms, a thorough screening is crucial. So the laser barrage should be considered if there is a tear or a lattice in such scenario. And even if we don't find any break, we should consider a close observation because they may develop in near future. We also need to understand that PVD can be accelerated by trauma, cataract surgery, a PCR in these scenarios, and these cases needs close observation. So this is a case in which this was a 26-year-old in which we usually generally doesn't expect a PVD, but we can see that is a pathological myopia post-ICL and there is a V's ring. He had 2 HSTs and we did a scleral buckling, and we can see that the vision improved well to 6/9 and he is maintaining it. Whereas in this patient, the same patient with MTM in the right eye, he had a left eye total RD with PVR with macular hole, and it was already 4 to 6 weeks late. In this scenario, we did a PPV with inverted ILM flap and silicone oil injection. The visual acuity just improved to 636 because of the presence of the scarred CNV and because of the longer duration of retinal detachment. The other scenario we need to be very cautious about the RD secondary to hereditary vitreoretinopathies, The pediatric cases with myopia can also be case of a hereditary vitreoretinopathy like Stickler, Knoblauch, Marshall syndrome. So these cases tend to have a very high risk of pediatric RD, bilateral RD, giant retinal tear, and they have a very strong vitreoretinal attachment. So these cases need a regular fundus evaluation. I would consider every 2 to 3 months, and I even advise a home monitoring for vision. I ask the parents to close one eye and examine the other eye of the patient and check what the vision is, at least on a weekly basis, to make sure that they have not developed any vision loss. And we also have to consider screening of siblings. So this is my last case, a case presented with right eye retinal detachment. The kid was a special child. The patient had a retinal detachment with choroidal detachment, and the left eye was lost due to a neglected retinal detachment. So here we can see that, like, once we did the drainage of the choroidal detachment, then we proceeded with vitrectomy. Here we can see that, like, there is a temporal giant retinal tear with crumpled and rolled the edge of the break. We can see that the vitreous is membranous, which is usually due to hereditary vitreoretinopathy. We tried to induce the induce the PVD anteriorly. The vitreous was strongly adherent. We used triamcinolone, and then we gently removed the vitreous spaces as much as possible. And once the posterior pole was cleared, then we injected PFCL to stabilize the posterior pole, and the vitreous spaces was advanced. The vitreous spaces was peeled anteriorly as much as possible. Leaving these vitreosclerotic membranes carries a very high risk of recurrent detachment. A subretinal band was also noted, which was removed. We used light pipe as a fulcrum to remove it completely. Despite this, we can still see that the edge of the GRT was still taut and crumpled. So we proceeded with a bimanual dissection, and we made sure to remove all the membranes which were present at the edge of the giant retinal tear. So once all the membranes were removed and the peripheral vitrectomy was completed, we injected PFCL and flattened the retina. So once the retina was flattened, the PFCL was filled up to the edge of GRT, and the laser and the edges were diathermized, and the laser was done. So once the laser was completed, we did a fluid air exchange. In this case, we also injected intravitreal methotrexate, as it has been shown to reduce the risk of recurrent RD, and silicone oil was injected. So to summarize, we should be aware of all these threats. We should consider educating the patients to identify the warning signs and to consult and ask them to consult as early as possible. We should make sure that we examine these patients regularly to detect these threats. A prompt treatment and regular treatment would help in maintaining good vision in these patients. Thank you.
Thank you so much, Dr. Pradeep Sagar. Very well compiled, and in fact, one of the most lucid talks I've seen about the risk of retinal detachment and the myopic problems in a high myopia. Just a few questions for a comprehensive ophthalmologist. When should we start screening the retina for the treatable lesions or the peripheral degenerations or holes? At what age and what level of myopia?
Yes, sir. Like, as we were discussing in the presentation, myopia, when we talk about myopia, it's not just about the lattice and holes. Particularly if it's a pediatric age group, like particularly 3 years, 4 years, like coming with myopia of around -8, -9. So these are cases in which we also have to consider a possibility of hereditary vitreoretinopathy. In these cases, we may not see a lattice or a hole. We may just see WWOP, the white without pressure, but these cases have a very high risk of retinal detachment. So we must not just be assured that, okay, the patient doesn't have a lattice or a hole, and we should not be assured in these particular cases. The moderate myopes are the one in which there would be a lattice and hole, and in general, the lattice and holes can be present in 6 to 8% of general population, and in myopia, it increases to around 33%. Not all holes and lattices are harmful. Unless they are symptomatic, I usually don't consider treatment for these cases. But once we know that these patients may undergo a procedure which will accelerate the PVD, probably those are the one in which we have to be even more careful. And if we see that there is a lattice with the hole, some people would consider laser barrage even if there is no detachment. And some people definitely do consider only a close follow-up. There's no definite cutoff to say that this is the age group beyond which I would be screening. Like rather, in a younger case, we should be even more worried about the hereditary retinopathies. And if the patient is like once they are beyond the pediatric age group, they are in a condition to be able to identify the warning signs. That makes things easier actually. So if there is no risk factors as such, and the patient has a lattice, probably we need not really worry too much. But we should. I usually ask them to regularly get an examination once in 6 months or yearly, and make sure that they have to review immediately if there are any warning signs. We can't generally say a specific age for that.
No, but can I have a different perspective? There's a 10-year-old boy who has myopia, of course, has a lattice with a hole. Okay, absolutely asymptomatic. But is it not a time bomb in the eye that we can just keep watching? If they don't come for a follow, that's a risk is there. And retinal detachment have its own problems. Just a barrage laser, though less invasive, definitely has a role. Don't you think that we should be over treating the lattice with holes than just watch?
This is always debatable, sir. Like, this is something which probably we don't have a clear-cut answer. So we can speak in both the terms. Like we can argue that like by doing laser we are not really causing any major harm. So by doing laser we are making sure that the hole is barraged and the risk of RD will be definitely reduced. But if we see that way, like the incidence of lattice and holes is around 6 to 7%. Like, can we treat every 6 to 7 of 100 cases? That is one thing. Second is like all these cases need not always result in retinal detachment. So like yeah, it all depends. Like maybe like if I take my like my view, like when I started my practice, I used to probably laser every lattice. Like then probably I shifted to lasering only the lattice with holes. Now I don't do unless I feel that there is an issue which can really result in a problem. And there are scenarios, particularly if there are lattices and in a particularly hereditary vitreoretinopathies, there are like once we do laser, there is a chance that there is acceleration of PVD and itself can result in faster development of PVD and even retinal breaks. So we are never assured, but definitely if there is a hole and if there is some amount of subretinal fluid around it, I don't really think I do laser, but only holes. I don't say that we should not do. Right now, I am not doing. I don't know, like in future, how I may change my perspective, but right now, I am not doing.
Last question about the myopic maculopathy. For a person having high myopia, like how frequently you advise macular evaluation and what gadget or what is their strategy and how to ensure that they will never lose the central vision due to maculopathy?
Like earlier, we used to make sure, like we used to discuss and mention that patient has to use Amsler chart, monitor at home, but those are not like really like it's very difficult for someone to be convinced to do it regularly. But as I was mentioning, the choroidal neovascularization is usually symptomatic. So we should make sure that if they have a symptom, they should come back immediately. That education we need to give. And this atrophic maculopathy is something which we cannot control. Myopic traction maculopathy is generally slowly progressive, so a regular evaluation once in 6 months should be sufficient. And OCT is a very good tool in identifying all this. And when we talk about OCT, it should not be a single line scan which just runs through one single scan through the fovea. We need to make sure that we screen the entire macula with probably a dense raster scan or a 3D macula in which each section of the macula is seen so that we will not miss a single lesion in the early stage. And particularly if they have one eye CNV, they are the patients who definitely make sure and they come very early if they pick up a symptom. And OCT is definitely a good tool in these cases. And it's not a recommendation, but I don't hesitate to get an OCT at least if there is a case of myopic maculopathy and there are these atrophic changes. I don't hesitate to get OCT once in 6 months.
Thank you so much. Very clear thoughts, Dr. Pradeep Sagar. Thank you so much.
Now we have a last talk. Deepak
Virat
Meghur
Kohli.
sir. Yes, Deepak Meghur sir is a finisher.
Okay, thank you for the
Sir, welcome.
opportunity. Yeah. Thank you for the opportunity, KP, Ravi, Shivyogi. I'll be speaking on cataract surgery in myopic eyes. And cataract surgery. So it is quite challenging in the sense that, the anatomy is slightly different here compared to our routine ones. And we have certain difficulties to encounter. The first obviously would be, deal with the biometry part. So first, let me quickly go to the biometry part. So look at this axial length. This is 30 axial length here. And we have got a deep chamber, and white to white is also will be very high. So this is one of our patients recently, and this is the challenge. Apart from that, we have a low scleral rigidity in these patients. That really needs to, share the collapse of the chamber frequently. And these are the problems which we face anatomically. So moving on to the biometry part of it and IOL selection. Now, the first question here would be like, this is probably the most primary challenge, accurate IOL calculation. The preferred method obviously is going to be your optical biometer, but it's not a mandatory thing. Like, if you have immersion biometry, you can as well go ahead and do it. But the challenge really comes only when we are dealing with the staphyloma part. Post-staphyloma parts, it becomes really challenging to do with your immersion biometry, and these optical biometers do help us here. The second obvious challenge will be if the patient is already undergone a refractive surgery, then calculation of the lens power becomes a challenge. So these are the things, but with the advent of good biometers and understanding of better formulas, it is not rare for us to hit the desired refractive outcomes in these pathological eyes as well. So obviously optical biometry is the preferred one, but don't forget the immersion biometry. It does help. Looking at the fundus does help us, to rule out maculopathy as was being discussed previously, because the choice of intraocular lens becomes very important. Now, moving on quickly to the formulas which we have. We have got multiple available options here, like, SRKT and Barrett's Universal 2 and Haigis. Of late, what I have realized is you need to use a combination of Barrett's, Keynes, and Hill RBF. You take an average of these three. Usually, it gives a good power. Even SRKT is good, but again, it has to be in combination with all the three. So you have to take an average of these things. The goal here is to avoid an hyperopia, post-operative hyperopia. So my strategy always is to ensure that we aim at least minus 0.5 above. So this is one case where we had done recently. Other eye, we opted for a -1, and this eye, we are opting for minus 0.33 as the residual refractive error. So avoid hyperopia, tend to be able to ensure that the residual error is around some about minus 0.5, and take the average of these three. Now, the next question would be IOL selection, monofocal, torics, or multifocals. Okay. Well, the safest option always is going to be monofocals, because these eyes are pathological, and monofocal always give, the contrast is not compromised. And there's a reason why it's always safer to tell that. But however, whenever there is a patient has significant astigmatism, and provided we have the lens power available for that particular range in toric should be used always. There is no question about it. Now, the big elephant here would be what would be, about the multifocal lens. An important comment about toric lens here would be, because we're dealing with a large capsular bag, there is always a tendency of the lens might rotate intraoperatively or post-operatively. The stability might not be good. So in these situations, what I have felt is I have used the larger size CTRs, so that it stretches the equator of the capsular bag, bringing the posterior capsule slightly up. So the adhesion between the posterior surface of the lens and the posterior capsule occurs very fast. By this, we are hoping that the postoperative rotation of the lens is minimized, and we have got decent outcomes even with toric lenses whenever the powers are available. Obviously, you don't get those powers anything less than 10 diopters of lens, so we need to be aware of that. And now moving on to the more multifocal lenses, the trifocal lenses. Well, obviously nowadays many of our patients are interested in these multifocal lenses. See, at the outside, you can just argue it that, because there is a reduced contrast in myopic patients, and on to add on, we're giving a trifocal lens. It's going to again reduce the amount of contrast available. So should be avoided. But however, I've used in quite a number of cases, about where the power is available. The problem is, you don't have availability of these trifocal lenses in these powers. In anything less than 12, I don't think we have any trifocal lenses. But if the macula is healthy, and if you roll out other risk factors like angle kappa, high angle kappa, and all, if the patient is suitable, then you can consider after adequate counseling, and if you're sure about your biometry. So in very high myopics, obviously you don't have a choice, that you don't get lenses only. But anything in moderate myopia, maybe about 12 diopters, where you have an option, lenses are available, you can still consider, with a caveat that rule out other red flags there. Macula should be healthy. Look at the angle kappa and angle alpha, and then take a call. The biometry again is going to be a little bit tricky, because the effective lens position is going to be debatable. But with the modern formulas, we are able to hit accurately even in these multifocal lenses. So it should not be a total taboo, but use with caution. That should be the thing. But anything which is high myopia, where you don't have an option, then obviously monofocal lenses still rule the roost, and they are the best choices. The next question would be like, what would be the anesthesia type? Now, when you're going to do this, the first thing would be like anesthesia. What anesthesia is safe? Topical or intracameral anesthesia combination is probably the safest, because we avoid the needle. Needle, because there is a higher risk of glow perforation in these long eyes, so it needs to be avoided. In situation where the patient is very anxious or very sensitive to pain, it is worthwhile to go ahead and use the subtenance approach with a blunt cannula rather than using a needle. So just make a small peritomy and then use a cannula to give it and make the patient comfortable. There's no situation where you want to operate with the patient being uncomfortable, just because to avoid the risk of having a glow perforation. So that much sensible we should be, and it's a reasonably good choice. Just make a small conjunctival peritomy and you should be fine. Now moving on to the next thing. Now intraoperatively, what challenges do you expect here? The basic challenge is, when we look at these pathological myopias who have got axial length of 30 or above, the chamber is extremely deep, and you feel like you're operating in the well, literally in the well. So that is a major concern here, and it is not very difficult, but there are certain things like, there could be a possibility of a reverse pupillary block because of the posterior movement of the lens iris diaphragm. And the first strategy when you want to avoid this is just lower down the infusion pressure or the bottle height. Okay, so you need not have to have active fluidics, any machine you're using, just lower down the bottle height. Assuming if you're operating on an average patient, 90 centimeter bottle height, just get down to maybe 60 or 50. And also ensure that you're also covering up for the bottle height by lowering down your flow rate and vacuum. Because ultimately the principle is that you should not compromise on your chamber stability. So if your chamber is not being stable at 60 centimeter, just get down your flow rate and vacuum as well. The next would be, how to prevent this reverse pupillary block syndrome. If you use a low bottle height, the incidence of this lens iris diaphragm retropulsion syndrome itself is decreased. But in this situation where you're expecting something like this, one simple trick could be, use a second instrument, just go in and lift up the iris, just lift up the iris with the cannula or something, just lift up the iris before introducing your irrigation. That ensures that you don't develop this the sudden reverse block syndrome or the lens iris diaphragm thing. The bigger challenge here would always be to get a right rhexis. The reason being, you've got an extremely well-dilated pupil, you've got an extremely bigger wide-to-wide diameter, and usually as a psychology, we just try to do a rhexis in relation to the pupil diameter. So we may end up doing an overtly large rhexis. So that's the reason. That is one thing which we need to avoid, to ensure that the lens centration is better or is good for life, we want to have a very small rexis. So aim for a very small rexis, 4.5 to 5 millimeter. Even if you go to 5.5, it's okay, because we want some amount of the lens overlap to the entire optic of the lens. That ensures that you have a reasonably stable. You can see there is a mild eccentric rexis. It was in the previous case. This is a bigger challenge here. So this is how it should be. Like, we want at least 360 degrees overlap in these large eyes. The reason being, these hydrophobic lenses, if they stick there for first few couple of days or a week, they're not going to change the position. So that's the reason why we want them to stick around, and getting this proper access is critical. So we can use these corneal markers just to help us guide, get us this appropriately sized rexis. But usually most of us, after doing so many cataracts, mental marker, what we use, that should be good enough. So the mark is faintly seen, and then we go ahead and complete. So there's nothing much for phacoemulsification. This only thing is, the secret is to get the appropriately well-centered and sized rexis. The nucleus management, the choice is going to be the surgeon's preference. So whether he would want to have a direct chop, or he would want to have a sculpt, stop and chop. It depends upon your judgment, your comfort level. So either way, you just ensure that the tissues are handled gently, because the zonules are relatively compromised, weak here. So especially many of these cataracts would be having a denser nucleus, because the patient would have prolonged the surgery or delayed the surgery. Be a little bit gentle. Choose the nucleotomy of your choice. You should be fine. Again, ensure that you are pulling the fragment out of the bag and then emulsifying. You're blessed here with a very deep antechamber, so it is very cornea friendly doing surgery in these cases. And the role of CTR in myopic eyes, do you really have a role? Well, in a regular case, maybe I would not put, but any case where I'm using a toric lens, which has an axial length more than 24, 25, then I would probably use a toric lens, a CTR. Just to end, the explanation is, we want the CTR stretches the back, pushing the posterior capsule a little bit anteriorly. This ensures that the lens sticks onto the posterior capsule much more earlier, and hence the rotation of the lens in the early part of the posterior period is minimized. That is the idea. Well, it's debatable. Some people don't like to use it, but it has helped me considerably, especially when using toric lenses. So postoperative refractive surprises, yeah, do they occur? Yeah, they can happen, because as you told, these are all, these are outliers. They don't fit into many of your formulas that what we calculate, and the estimated lens position is again it's assumed, not really accurate. So we may end up getting postoperative refractive surprises. But you should be prepared. The best way to deal with this is counsel the patient beforehand only. Most of the times, what happens is the patient would be very happy post-operatively. Simple reason is their preoperative vision would be so bad. So even with a residual refractive of about 2 also, they would really be very happy. So that should not be a major concern. But what is important is to counsel them that lifelong retinal monitoring is mandatory. So you can screen them preoperatively, rule out any pre-detachment lesions, and even after surgery. I think it should be a prerequisite that they should be evaluated every 3 months for their lifelong follow-up. That is important to just rule out, because these people are vulnerable to develop retinal detachment. Always keep looking at it. Posterior capsular pacification. Now, this is a challenge. This is what we are worried of, and we don't want it. So choose the lens wherein we don't want to yag them, because yag again increases the risk of posterior capsular, increase the risk of retinal detachment. So we want to avoid it. So my preference always is to use multi-piece, three-piece hydrophobic lenses, especially the expand series of the Alcon. They come in the normal thickness, and in my experience among all the lenses, this lens has been the one which give the least PCO rate. So the choice of lens would be basically the lens which causes least PCO. Hydrophilic lenses should be avoided, I guess, because definitely the chance of PCO is higher. Of course, no financial interest in this. And in the event where you would want to, if the patient develops a PCO, now what are the strategies? Should we YAG it or no? So one option would be like, I have always went ahead and polished it later on. So you can always yak them with very low energy in a controlled way. But I have also gone in and polished about 3 or 4 patients. The only problem with that is they keep coming back. The PCO keeps coming back. And eventually there is a time when eventually I went to go ahead and YAG it also. So retinal detachment is a problem. So that is one thing which we have to be concerned. This is one video where I've gone in and tried to just do the polishing. This was a patient who had operated many years back. And so this is a summary. So use new formulas and aim for a slight residual myopia. No, you use an automatic technique to protect this fragile zonules. Ensure perfect IOL centration, and this is possible only if you have a good, well-centered and appropriately sized rexus. And obviously, retinal screening pre-op and post-op is mandatory. Thank you so much for the opportunity and attention.
Thank you, Dr. Deepak. According to you, is the pre-operative evaluation biometry is more challenging or the intraoperative challenges for you?
No, intraoperative is not much, except for the rexus part, not much. Getting the right power and all those things is critical. Intraoperative is not much different, frankly speaking. Getting the rexus right is the important thing. Like, invariably, many people we end up getting a larger rexus than what is desired.
No, but the high myopes have a propensity for the capsular phimosis as well as the possibility of capsule shrinking and all that. Do you think a smaller axis predisposes to such a complication?
Yeah, that theoretically, I've read about high myopia causing phimosis, but frankly speaking, I feel the larger axis causing a decentered IOL is a bigger problem than a smaller axis causing a phimosis. First of all, the incidence is very low. Even when it happens, we can just release that phimosis by doing YAG on the intercapsular margin. But having a decentered lens is a bigger problem for me in these bigger eyes. So that's the reason I would say that having about 5 mm axis is ideal.
And your choice of a three-piece lens is only because of availability, or if you were to have a large diameter single-piece lens, you would actually prefer that?
No, I would still prefer the three-piece lens because of my personal experience. I have realized that the PCO rates are significantly lesser from this particular model, even compared to the same company's single-piece lenses.
No, no. Also,
So
you
that
mean
is the
the
reason.
stretching because they have a overall length is more. They probably stretch the bag well, and there is no laxity of the bag.
Yeah, that is one thing. And second, the squarage which we get of this multi-piece lens is much more squarer, and that is one of the most important barriers which I feel. And the angulation of this thin haptic of a multi-piece and the optic, the angulation which they create is much more different than the thicker haptic of that. So you don't create that angle, and this angle effect is what prevents the PCO formation. So that is the reason why I believe that they perform better than the single piece lenses.
Right.
Excellent video and excellent uh, presentation, Dr. Deepak.
Sir, thank you, sir.
Now, and what about the patients who have cataract? I think Dr. Pradeep is also there. He can also answer. People who come for a pre-operative, high myopes pre-operatively, how easy or difficult it is to actually look for peripheral breaks or any treatable lesions. And when, if we can't probably see them well. So first of all, unless it's a mature cataract or something, it's more of a nuclear cataract. We can still, the peripheral retina is seen by with a bright light for most of the experienced eyes. So does it still mandate that we should do a post-operative retinal examination? And what is the time duration after cataract surgery that we should be doing it? Dr. Pradeep, you have any comments on that?
But regarding examination of the fundus, definitely, like if it's nuclear sclerosis, like the visibility will not be really hampered. Our view will be as good as a clear lens with nuclear sclerosis. unless it's almost like a grade up to 4. 4 is the one in which we will not be able to see. PSC will compromise our thorough screening, but at least we will be able to see to some extent. But the issue is like even if we identify, will we be able to do a laser is something which is not always possible. Maybe if we find that there is a lesion and if we think that it's a tear, mostly we will try laser as much as possible, even if the media is not very good. But if it's only a lattice and if the media is not very clear, like we will not really go ahead with an immediate laser. We will definitely ask for a cataract surgery to be done. And post cataract surgery, like the risk of the PVD definitely accelerates post cataract surgery. It's something which is proven beyond doubt. So the PVD, when it occurs, if there is a lattice, there is a definite chance of a retinal tear developing, but not that every patient will develop. Again, that's that's left to individual practice. Some people do consider laser barrage for all lattices before a cataract surgery in myopia and even in non-myopic cases also. And there are a few who consider only if it's asymptomatic. And by guidelines, if you go, it's usually the symptomatic lattices which has to be treated. So as of now, like I treat only symptomatic lattices, not all lattices, even in myopia.
I think the
The
point to
patient
be
present
taken
with
is to do a very clean and a safe surgery. No posterior capsular rents and no vitreous disturbance in a high myope. That will multiply the chances of post-op, PVD induction and the post-op retinal complications in future. I
True,
think
sir.
that's probably a very important thing for all beginners, that wherever possible, take extra care not to have any vitreous disturbance in a high myopia.
Yeah, one more point, KP. Common question asked is, assuming the power is just 0.5 or 1, can we opt out of putting the lens off?
Yeah.
Can we leave the patient aphakic? This is a very common question asked. Okay. Suppose the lens power is can +1, -1 or something, 0. My recommendation is you should still go ahead and put the lens, even if it is 0, -1, +1, whatever it is. The reason is we don't want to leave the bag. Two reasons. One is PCO formation is there. Second would be the phaco. If you just leave the bag empty, the amount of
Endophthalmodonesis.
phacodonosis what we get is much more higher.
Yeah.
So
In
that's the
fact,
reason why even if it is 0 power,
yeah, I think one barrier for the endophthalmodonesis, the shakiness of the vitreous post-op, which is going to induce PVD.
yes,
And probably
yes.
in future, should have a thicker lens, because almost a 4 mm lens is replaced by a 1 mm IOL. That extra space further actually, is a risk factor. So probably in high myopes, just not a lens, a thicker lens probably would be most welcome to fill the same space.
Sir, can I ask one question?
Yeah, please.
Sir, actually, in case of pediatric cataract, I have to do a PPCR, I have to do a vitrectomy. So in most of these high myopes, when I do a PPCR and I go in for a vitrectomy, it becomes an extensive vitrectomy. The vitreous keeps on coming out. And eventually I have noticed after a period of 1 year, 1.5 years, they tend to develop an RD. So how can I proceed with the pediatric case where vitrectomy is mandatory? I have to touch posterior capsule and vitreous.
This is to Dr. Pradeep or Dr.
Anybody can answer for me, sir.
I think Dr.
After the
Pradeep.
RD happens, maybe Pradeep sir can answer, but before
No, I
that,
think Dr. Pradeep would probably start.
Yes, sir. It's a definite issue, sir. Like once we do a cataract surgery in a kid, and particularly a myopic, we have that we should be prepared for it. Like there is a definite risk of retinal detachment. But at the same time, it's not that possible that we will avoid PPC, like avoid doing a posterior capsular access. This is a real problem that we all do encounter. There are certain challenges which we face, particularly like though the central opening is there, the peripheral opening will not be there. So the visibility will also be poor. Examination will also be difficult. Screening for retinal breaks is also difficult. So these are some of the challenging scenarios. So like it's difficult to say. Like it's like we can't leave it like that. And definitely there will be visual axis of pacification. And for that again we may have to do a surgery again. So which is not which definitely don't serve the purpose. So we have to go ahead and do it. And make sure that we closely monitor, we keep examining the patient. And as I was mentioning, a patient education, and the parents have to make sure that they examine that eye regularly. Like I always tell them that some, like if they are educated, like I will ask them to see that apps which are available, the vision testing apps, and ask them to check individual eye vision regularly on a regular basis. If they don't have, like if they are not that educated, I at least ask them to make sure that do they really find any difference in the way the child was performing with that particular eye. I always insist that they have to keep a close eye and close observation for these things on a weekly or once in 2 weeks at least. Because early identification, if we identify these cases early, we can definitely do a good job. But if it's something which presents late, sometimes they come when they develop secondary complications, like the patient, there is an iridocyclitis, there is the choroidal detachment, the patient has pain, then they come. So if they come at that stage, it's pretty difficult to do anything.
I think the moral of the story, every pediatric ophthalmologist should have a friendly retina person around.
I have.
You have.
So yeah, I wanted to ask, like, I wanted to suggest one thing.
Yes, sir.
In these myopic kids, if at all, if you're operating maybe around 3-4 year old, if they're myopic, maybe you opt out of doing vitrectomy, do a rhexis, posterior capsule rhexis only, and if possible, try to prevent the antihyaloid rupture. Push the multipiece lens beyond that
Optic
posterior
capture,
capsule.
you mean.
Optic capture in the posterior capsule rhexis.
Posterior
I
cap.
understand.
The haptics are in the back. Haptics are in the back. Optic goes behind, but is possible only with a multipiece lens.
Yes.
Okay.
But again,
So
that
you have to use
becomes
a
tough
multipiece
because
lens.
the anterior chamber is so deep, and as such, doing a PPCR itself becomes
Yeah.
very tough in these
Very,
children
very tough.
because the
Yeah, I
PC is
understand that
very.
PPC, because in these patients, the chamber is very deep. Try staining with the trypan blue. Sometimes
Yes,
it
sir.
does help. It also stiffens just a bit. Try staining with the blue. And you know what? Luckily in myop, the glow will be slightly better. Pediatric eyes, the red glow is very bad. Okay?
Yeah.
Red glow is very bad. You don't see the posterior capsule only. In myopic pediatric patients, maybe slightly better. Maybe slightly. Because you may have, if it's in worst case scenario, try to stain it just a bit and then try. The idea is push the lens back, and that will prevent the lens epithelial cells growth marginally for at least 2 years. That is the one thing. That's one thing which you can try.
And
Yes,
one
sir.
important point of contention, Dr. Deepak Megar also alluded, is having a PCO in a high myopia. A lot of people can do a yak capsulotomy, I think, which increases the risk of posterior segment complications. Is it wise to actually go in and try to, I mean, evacuate or vacuum clean the posterior capsule or a capsular polishing versus a yak capsulotomy? Dr. Pradeep, do you think that doing an yak capsulotomy increases the risk of retinal detachment versus retaining the capsule? Is it a
Definitely,
theoretical risk? Is it a practical risk?
definitely, ACAP increases the risk of retinal detachment, but when we compare anterior vitrectomy versus ACAP, definitely ACAP is a bit safer theoretically for sure.
No, not for kids. I'm saying routinely in adults. In adults, high myopes, because they are high myope. After cataract surgery, we forget that they are high myopes because the refraction doesn't indicate anything. So many a times, unknowingly, people do yak cap, and that increase the risk. So do you really advise that if we can actually do a capsular polishing and keep the capsule intact?
So to be honest, like I don't have any personal experience with this, but I have seen a few presentations on capsular polishing for PCO. Definitely, theoretically, it would reduce the risk of disruption of the anterior highlight. But one of the reasons for accelerated PVD post cataract surgery is the fluid which goes into the vitreous cavity during any surgery, even with ICL. So the fluid which goes into the vitreous cavity accelerates the vitreous liquefaction. So whether how much of, like during capsular polishing, whatever the fluid that we use, like how much it goes back, how much it really results in the vitreous liquefaction, how much it accelerates PVD, we don't have a direct head-to-head comparison to say that if we do these many cases ACAP and these many cases polishing, whether really it make a difference, it's difficult to say. Definitely, there's a capsular disruption and anterior disruption with ACAP. At the same time, the fluid which goes behind can also result in a vitreous liquefaction in any kind of a surgery which we do. So it is difficult to say, to be very, unless we have a very very well conducted study, then probably we may have an answer. But right now, I don't think I have an answer.
Thank you so much.
Dr. Megur, one question.
Sir.
Uh,
Sir.
Your experience regarding clear lens extraction and IOL as a refractive procedure for high myopes?
I have not done personally many, sir, and I'm not also agreeing with that. So that's the reason I don't do much. I don't because I feel the retinal problem is much more severe. So I really don't advocate it much. So I don't have any experience on that. I'm not for it, rather I should say.
Yes.
I'm more conservative, old-fashioned little bit.
Dr. Shivyogi, I think it's time to conclude, I think.
Shivyogi?
Dr. Ravi, you only conclude. No problem.
Shivyogi is there. Shivyogi. Unmute. Shivyogi, Dr. Shivyogi?
I think he's muted.
No, he's...
He's not muted, but his voice is not heard there.
Okay. Some technical problem.
Shivyogi? Unmute. Okay. Anyway, on behalf of Shivyogi, our chairman, I'll conclude this with we had a very nice talk. Unfortunately, we did not have many participants on YouTube also, not many questions also. But as if KP sir is there, all our doubts will be cleared because he'll ask everything when they are very practical. I sincerely thank Deepti, Rupashri, Pradeep Sagar, and Deepak Megur sir. I also thank our KP sir and Shivram sir. Shivram sir, you stayed all throughout. It was so nice to see you and encouraging for us. We'll have more of these. And KP sir has a full 1 year roadmap, and he has provided all the possible help, whatever is needed from the pharma, micro. And I also thank our Navneet. He's there. Navneet is there.
Navneet is there.
Yeah, I think he has done a fantastic job. Last moment, all these things are settled down. We were skeptical because ours is the first time, but for you people, it is not the very new. And thank you very much. Everything went very well. We'll have more of these as KP sir will be guiding us all throughout. Anything is there? I think I will conclude this, sir. KP sir.
Yeah, thank you so much, everyone.
For this opportunity, sir. We are always there. Yeah.
Thank you, Navneet, and thanks everyone for making this first webinar very successful. And this link will be available after 2 days, and there'll be many more people. Normally, most of these webinars, there will be very few live spectators, but over a period of time, they will actually see at their convenience and look into this. So thank you so much for making it so informative, and good night.
Thank you.
Good night.
Bye.
Thank you.
Thank you, sir. Good night.
Good night.
Good night to everyone, sir. I'll end the meeting now.
Yeah. Thank you. Bye-bye.